Okay, this video is going to be about schizophrenia and antipsychotics, which are also known as neuroleptics. Just real quick, looking at the anatomy of a neuron here. This is the cell body, and action potential begins here at the axon hillock. It transfers down into the axon terminal, and it causes calcium to come into the axon terminal. These neurotransmitters are then released. They travel across the synaptic junction. They bind with a receptor on the postsynaptic neuron. Okay. We're going to get in some good stuff. We just got to go through this real basic stuff real fast here. Okay, just real quick, a little bit about how synapses behave. A synapse does not just stay the same after you give a drug. A synapse responds to the drug. It tries to fight the drug. So here, for example, is a normal serotonin synapse. We're going to be talking about antipsychotics, but I just already had this drawing of serotonin synapse. So let's just real quick look at it because the principles are going to be the same for whatever the medication that acts on brain neurons. So at the brain neuron of a serotonin synapse, serotonin is released into the synaptic cleft. It diffuses across the synapse to the postsynaptic neuron, and it will then bind with the receptors, which will exert an effect on the postsynaptic neuron. Now here's the reuptake transporter, and the neurotransmitter goes back into the presynaptic neuron. It can be repackaged into one of the synaptic vesicles. It can also be converted into other things, but this reuptake transporter is very important. It's called the serotonin reuptake transporter in a serotonin neuron. And here's a serotonin selective reuptake inhibitor. So if you block reuptake, now there's going to be more neurotransmitter in the synaptic cleft. In this case, serotonin, but it applies to any neurotransmitter. So what's going to happen? Well, the neurons will try to compensate for that. Because there's more neurotransmitter in the cleft, the postsynaptic neuron can downregulate its receptors. Now it only has one receptor. Before, it had multiple receptors. It can also upregulate, make more reuptake transporters. It only had one over here. Now it's got four. It can make more synaptic. It can make fewer synaptic vesicles. If it's sensing too much neurotransmitter in the cleft, maybe it'll just have fewer synaptic vesicles. We got a whole bunch of them here. I forgot to put the transmitter in them, but there's only one over here. So that's just the point. The synapse, the brain, will fight the drug and try to readjust. And then you get new side effects from these compensations of the synapse. And that's also why it can be hard to withdraw quickly from these drugs. Real quick, here's just a dopamine synapse. And dopamine is the relevant neurotransmitter for schizophrenia in particular, also for Parkinson's disease and some other movement disorders. So the action potential comes down the neuron. It depolarizes, so you get a transient positive charge inside the neuron. This depolarization activates the voltage-gated calcium channel. Calcium comes into the cell. The calcium entry into the cytoplasm elevates cytoplasm calcium. Remember, cytoplasm calcium elevation is key for making all kinds of things happen. That's going to be useful to know for lots of things. Okay, so the dopamine then, the vesicles merge with the plasma membrane of the synaptic cleft, and they release dopamine into the cleft. Dopamine diffuses across the synaptic cleft, binds with the DAR, dopamine receptor. Okay. Now, if you block the dopamine receptors with an antipsychotic, it's a dopamine blocker, specifically D2 type dopamine receptors, what's going to happen is now the postsynaptic cell will just make more receptors to make itself more sensitive to dopamine. That's also related to some of the side effects we'll see with antipsychotic medications like tardive dyskinesia, which is a very severe side effect. But just remember that the postsynaptic membrane can do things to adjust to what it thinks is the appropriate amount of neurotransmitter. Okay, schizophrenia means like split brain, psychosis, to lose touch with reality. The so-called positive symptoms of schizophrenia are delusions and hallucinations, having lost touch with reality, they're visible. The negative symptoms of schizophrenia are apathy and indifference, and these are present in variable degrees. Now, the marketing approach is to claim that schizophrenia is due to excessive dopamine, and that's popularly taught, but that's never been proven, so that is not known. In fact, Bragan, and we're going to talk a lot about Bragan. Bragan is this brilliant psychiatrist trained at Harvard who wrote this book here. This is the best book I've ever found for learning the pharmacology of psychiatric medications. It's called Brain Disabling Treatments in Psychiatry, Drugs, Electroshock. And this book, just to show you how much details, there's like thousands of well, I didn't actually count them. It looks like there's thousands. I haven't counted them. He said there were thousands, and there probably is. There's tons of pages of these small print scientific references to the literature, and Bragan's really smart. I've read a couple other books by him, and I'm impressed by this book. So I'm just saying, if you need to look up something about a neuropsychopharmaceutical, this is a good book, Brain Disabling Treatments in Psychiatry by Peter Bragan. There's other ones. As a matter of fact, I'll show you some of the other references, too. This is a brilliant book here by this lady psychiatrist, Grace Jackson. It's called Drug-Induced Dementia. It's a very clever book. Ooh, crap. My highlighter dropped. Okay, and I'm going to show you one other book that's a good book, Anatomy of an Epidemic. This one is by Robert Whitaker. He's got a lot of videos online. Grace Jackson and Peter Bragan also have several videos online. So anyways, well, what people are told, and it's sort of a marketing thing that they go, oh, well, there's too much or too little of a given neurotransmitter, therefore we must increase it or decrease it to get a proper balance. That's all BS. That's not true. Bragan specifically goes into all that, and Grace Jackson says the same thing, and Kelly Brogan will say the same thing, and they'll show you all the papers proving that they searched big time. Since the 1800s. They've been looking at brains at autopsy, and more recently with modern techniques, and they can't find any chemical imbalance for these psychiatric diseases. The antipsychotics became popular in the 1950s because they were able to, in a sense, be like a chemical straitjacket to subdue the patient, make them more apathetic, less public bad behavior like, public masturbation, things like that. So the persons working in the mental hospitals liked to basically subdue the patients, the ones that were agitated or causing problems in their eyes. But the problem is they also will cause brain damage. Now, according to Bragan, and by the way, I put page numbers for every reference to his book here, just because if anybody wants to look it up, you can go right to the page from the slides of my lecture to the book, and you'll find it. Okay, all antipsychotics cause a chemical lobotomy. Now, that's an important point. They all cause some form of essentially a chemical lobotomy, separating the frontal lobes from the rest of the brain, and to some extent the basal ganglia and the temporal lobes. Now, that's bad, okay? Now, the person running the mental hospital might like it if the patients have a lobotomy. They just sit in bed all day, apathetic, and they're easy to manage. But for the individual, that diminishes their chance of having a meaningful recovery. The more antipsychotics a person takes, the more brain damage they have, the more risk they have of tardive dyskinesia, which is all these twitching chorea-like movements, which make it even more difficult for them ever to be socially re-engaged with the community. Also, as it slows down everything, it also predisposes them to dementia. Think about Parkinson's, a deficiency of dementia. Well, a deficiency of dopamine is going to slow everything down. Dyskinesia, slow movements, and slow brain function, and neurons are actually dying and being destroyed. It's bad. We'll go into some of the mechanism of that later on. They actually have a component of mitochondrial inhibition, so they're mitochondrial toxin. They have a component of excitotoxicity, so they're an excitotoxin. I mean, it doesn't get much worse than that. An excitotoxin and a mitochondrial inhibitor. Bad. Okay, Bragan agrees with Thomas Szasz. Szasz is a famous psychiatrist. I did a profile on him as a psychiatry hero. And he would talk about how when you stick a patient with a label that's pejorative, you stigmatize them. And you basically are setting them up to be a victim for a very aggressive treatment. In the Middle Ages, they'd say, she's a witch, burn her at the stake. Nowadays, they'll say, she has a severe refractory depression, she needs a chemical lobotomy. And they won't say she needs a chemical lobotomy, but they'll give drugs that push towards that effect, or they'll put her in a chair for electroshock. We put a convicted criminal in an electric chair to, execute them. And now you're going to put a person in an electric chair to fry their brain? It's insane. It's crazy. It's like something from the Middle Ages. Okay, they literally will put a person in electroshock and shock their brain to intentionally cause brain damage, because that, in a sense, has an effect similar to a form of lobotomy. Bragan says electroshock is a form of lobotomy. It's rather frightening. This is what's happening. People think modern science is so advanced. Yeah, right. Okay, medication side effects typically get blamed on the patient. Like the patient will have a side effect. They go, oh, that's because of your mental illness. Let's treat that with more pills. That is a very common mistake that psychiatrists often make. Psychiatry drugs tend to induce an effect called spellbinding, whereby the patients are not that good at articulating their problems. And a lot of these persons are not that articulate to begin with, and then you give them brain damage from these drugs or electroshock. They can't say what's wrong with them that effectively, and that makes them even more vulnerable to more problems. It's tough to go through life no matter who you are or what you are, but man, if you're poorly articulate and you get in the wrong hands here, you could just get messed up pretty fast. In fact, Bregan says going to a psychiatrist is one of the most dangerous things you could do. A biological psychiatrist is going to prescribe a drug. And then he says all psychiatric drugs are the common ones for treatment of the common diseases are neurotoxins. Okay, so what's your chance long term of getting better? In the short term, maybe somebody's out of control and a psychiatric drug in that context, can have some validity, like an antipsychotic, but the longer persons stay on these drugs, the worse outcomes they tend to have. If somebody's got some news that I don't know, I'm happy to read it if you put it in the comments or something, but, my father was a psychiatrist, and he was a good guy. He was a good role model. He liked his patients liked him. He, tried to do the right thing by people, but as I got older, I looked up to my father growing up, and like I said, he was good to me, and he was a good man, a good role model, good father, husband, all that stuff. But as I got older, what I realized, after I went back and got educated myself and I was in my 30s, is that, like a lot of people, he just accepted whatever he was told. So if he's told something, in the standard marketing brochure from the drug company, or what's considered the standard for his field by the associations and all that, he would just believe it and he would just go by it. Versus, when you start to really read in depth and learn about stuff, you learn not to just believe everything you're told or everything you read. You have to say, does this make sense? What does my experience show? What do other sources of information show? Because you'd be amazed how common that is. I would say most doctors, most PhDs I know, just accept whatever is the dogma of their field. And they actually turn their brains off. I told you, I have one of my relatives, and he was having his kids spray Roundup glyphosate on, he sold Christmas trees as a business in December, and he would have his kids spray it on the ivy weeds growing in there. I'm like, you're having your kids spray a herbicide. Are you out of your mind? He goes, oh no, the company says it's safe. I'm like, you believe the company? Okay. So, whoever's selling these antipsychotics, they're going to tell you they work better than they do. They're going to tell you they fix a chemical imbalance. But when you start digging through the literature, you'll see there's no evidence of that. There's no convincing evidence to support that. Brogan says, and Jackson will all tell you, there's no convincing evidence for a neurotransmitter imbalance in any of these major psychiatric diseases. Okay, the history of psychology and psychiatry. Before 1850, people would talk to their family, to friends, or to a priest. After 1850 in France, they'd go to doctors quite often, like Dr. Charcot. He was a famous neurologist, became famous for treating the hysteria patients. There's a beautiful picture of Charcot at the Salpêtrière, the name of his hospital in Paris. You can see that if you go to Wikipedia. It's a cool painting. Freud then went and trained with Charcot, and he developed, Freud, the field of psychoanalysis. And it really focused on the patient's past, emphasized repressed sexuality. His two big proteges were Adler and Jung, and they kind of developed their own methods of psychotherapy, less emphasizing repressed sexuality, more emphasis on self-individuation and overcoming feelings of inferiority, in particular with Adler. Other later famous psychotherapists were Rogers, Maslow, Beck, Burns, and they all had some good contributions. In the 1950s, drugs came along, and the antipsychotics became very popular because you could get easy control of these difficult patients, the ones that were difficult. It's like a chemical straitjacket, like a chemical lobotomy. Thomas Szasz became famous in the 1960s with his book, The Myth of Mental Illness. Benzodiazepines came along around that time, and they were especially used for sedating housewives to get them to accept their life, so to speak, was a common use of those. Mother's Little Helpers, the Rolling Stones songs came along around that time. And then things changed, though, in the 1980s. By that time, the biological psychiatrist, the one that emphasized prescribing drugs, had pretty much taken over psychiatry, and they'd pushed the Freudians aside. They'd pushed the Freudian variants, neo-Freudians all aside. and psychiatry became primarily based on biological, which means to treat with drugs. Okay. Now here's a funny thing from Bregan. He says, usually when you talk about the therapeutic index of a drug, you'll say it's like, 10 times higher to make the drug injurious to a patient than the therapeutic dose. And a dangerous drug would be something like some sedatives. It might only be 2 to 1, so you got to make sure you don't go too high on that dose. But here's the joke from Bregan about the therapeutic index of psychiatric drugs. He says it's 1. The toxic dose is the same as the treatment dose because the toxicity is considered the treatment. And that's a rather incredible statement for anybody interested in pharmacology and therapeutics, man. That's an incredible statement. So what he says is the brain damage induced by these treatments is what's called therapeutic. He says when you got a schizophrenic patient who's agitated, you give him a lobotomy. The lobotomy is what you, so to speak, wanted to achieve. And he says when you give a drug that does the same thing, that was the goal of the treatment. And there's always euphemisms, so it's called deactivation, almost like separating the rest of the brain to some extent from the frontal lobes and also to some extent from the temporal lobes and the limbic system. And some research will say that the drug is treating the mental illness, but Bregan doesn't put up with that. He says, no way, that's BS. He says, if you were treating a specific illness, you would get a treatment effect that only affects patients with the disease and not a normal volunteer. But if you give these drugs to normal volunteers, or you give them to patients for other reasons, like let's say the patient has some type of disease that someone thinks a neuroleptic antipsychotic is going to help, they get the same side effects, tardive dyskinesia, and the risk of tardive dementia and all this stuff. So one has to be very careful with these drugs. Bregan claims the whole story about neurotransmitter imbalances, never proven. It's a marketing ploy. He says there are zero, none, nada, no specific psych drugs for specific psych diseases. He says the entire concept in psychiatry of a specific drug for a specific common psychiatric disease is not true. And again, I have all the I have all the page numbers for these statements, and they're coming from Bregan's book, Brain Disabling Treatments in Psychiatry. It's an extraordinary book. Bregan's really smart. Watch his videos. See the guy. You see him, at first he looks like this sweet older guy. He's older now. But, man, you start reading the stuff, he's a bright, bright guy. Kind of like what McDougall is in nutrition. That's kind of like what he is to psychiatry. PET scans over the course of 6 weeks show a progressive decrease in frontal and temporal lobe metabolism in patients treated with antipsychotics. That's bad, okay? When the brain's not metabolizing, that's like what you see with dementia, okay, when part of a brain's not working. Again, he calls these brain disabling surgeries, and he says they're all like a lobotomy. And he says, oh yeah, these symptoms of positive, hallucinations and delusions will be decreased by these brain disabling treatments, antipsychotic, electroshock, surgical lobotomy. However, you get worsening of the negative symptoms, so-called negative symptoms like apathy, indifference, lethargy. The person just sits around, they don't care about anything. They kind of become zombie-like. Imagine someone in your family had one of these conditions. You don't want that to happen to them. You want them to hopefully get better. Now, they may or may not get better on their own. From the Soteria study, I showed a video of that recently. They had better long-term outcomes if they were managed, with thoughtfulness, respect, and love than they did if they were kept on these antipsychotics. Bregan says in his clinical practice, he does not use any psychiatric drugs. The only exception being if a patient's in the process of withdrawal, he'll taper a dosage to help them, enable them to withdraw off a medication. Okay, Bregan says, I already repeated that. He says the only neurotransmitter imbalances that occur are after they get a drug, just like those slides I showed you in the beginning. Now you can start causing problems with these synapses, but they've been searching for that for years, and they can't find any convincing evidence of that in humans whatsoever. Okay, talked about the brain compensating, like I showed you those slides of synapses. And then kind of like Thomas Schaas, he's the guy who wrote The Myth of Mental Illness, the other psychiatrist. Bregan says that none of the commonly treated psychiatric problems are genetic or biological in origin. Okay, there's a tendency to say, oh, that's genetic, therefore you must treat it with a drug or a surgery. He says, no, none of this stuff has ever been shown to be genetic or biological. And Bregan says this: we must love one another or we will destroy one another. Now, I know a lot of people think they're really hot stuff and they're really smart and they're like, oh, this should all be based on science, science, science. Okay, look what science has led to in psychiatry. They put people's brains into like the equivalent of an electric chair and they just damage their brains, okay? That's science without love, okay? Look at, people being kept on antipsychotics. Look at them closing down Soteria because they didn't want the competition for the antipsychotic medications. I really don't care too much about this psychiatric medication stuff. I was trying to understand excitotoxicity in neurons, and I'm like, well, where can I find more research on humans? And I'm like, holy crap, there's a ton of research on humans in psychiatry. So I got to look at psychiatry. I don't really care about this. I care about nutrition and food. But I'm shocked when I read this stuff. It's like unbelievable. I know some psychiatrists, and they're actually pretty nice guys, the ones I know. They're thoughtful, intelligent. I like them. I don't know them that well, but I like what I know of them. And like I said, my father was a good man, but there's a major weakness. And this is a common thing amongst doctors and people in other professions, to just accept and take whatever is the status quo. Oh, okay, we're supposed to put the patient into an electric shock machine and shock their brain and damage their brain, and that's supposed to help? Okay, I'll do it. They don't say, hey, isn't this stupid? Isn't this like an electric chair? I mean, a doctor that'll do that is one out of, 10,000 or less, like Bregan, like Kelly Brogan, like Grace Jackson, and some other ones. They're rare individuals, A doc like McDougall in medicine that'll say, hold on a sec, this is BS. I could cure these patients with diet. Why am I giving them all these drugs that don't help? And what I'm trying to say is, for me, it's a little tough to reconcile this. My father did all this stuff, and he believed in all this pharmacology stuff. Why is it that somebody can believe in these drugs when they're obviously toxic? Well, I think it's because, you get some patients improve just from placebo. A pretty high percentage of patients improve just from placebo. So if you're giving all these drugs and you're seeing a significant number of patients improve, especially in the short term, you could believe it was the drug. And then also, I sort of feel remember T. Colin Campbell, his father was a cattle rancher. It was hard for him to accept the fact that, all the stuff that, his family and his father did making all this meat was not really helping people. Thought it was when he's growing up. Neil Bernard, his dad was a diabetes doctor, and I'm sure he just prescribed the standard insulin stuff and thought that was what was going on. No one knew that meat made people sick. And so what I think is, maybe in the early days you could have said that maybe no one knew these drugs made people sick, but if you're seeing these patients every day, and if you just, open a book, I mean, Grace Jackson's book right here, Drug-Induced Dementia, Bregan's book, Bregan's written a whole bunch of books. I mean, it's pretty obvious. It's incredible how bad these drugs are. Okay, and by the way, I'm a neuroradiologist. I don't treat these patients. I don't prescribe drugs. I'm just came across this trying to understand neuronal function and neuronal mechanisms of neuronal injury. Okay, I was interested in excitotoxicity. I'm interested in mitochondrial inhibition. And then I just started studying this. I wanted to make sure I understood it. And I really wish these books would give me more about the pathophysiology and pharmacology. I found some papers that do, but it's a rather incredible and shocking story. And you look at this, 2006, in 2006, anti-cholesterol drugs, most common, antihypertensive, antidepressants. But antipsychotics, the fourth most common set of drugs, were an $11.5 billion market. So that means they've got tons and tons of money for advertising. And so you're always going to see people trained to do this stuff. And, I know what'll happen too. If the doctors say this is BS and they refuse to do it, they will hire a nurse practitioner to do it. And then if the nurse practitioner says it is BS, they'll have an RN do it. It's not going to stop. You can never change a system in that way. The only thing you can do is, as an individual, educate yourself so you don't become a chump and, get brain damage to yourself and your family from these drugs. All antipsychotics inhibit dopamine. Some also inhibit other neurotransmitters. Bregan says the newer antipsychotics, they're called atypicals, are no better than the old ones. They actually cause some additional different side effects. He says this so-called atypical term, in his opinion, it's a marketing ploy. Sometimes patients get treated with antipsychotics for other reasons, and they still end up with these terrible complications like tardive dyskinesia, all this twitching and stuff, and it can be irreversible. It can make it real hard for a person socially. And the other thing too is schizophrenics. They used to live if they could stay with their family or something in the community and not be on these neuropsychotic antipsychotic medicines. They would live a normal lifespan. Now they die prematurely. They're sicker. In a sense, if you're not going to do a surgical lobotomy, it's a way to almost chemically institutionalize these patients. Soteria showed that a lot of them actually could reintegrate into society. They could hold down a job. They could be married. Okay, they could function in society. Bregan claims the phrase antipsychotic effect of these medicines is a euphemism for deactivation effect, separation of the rest of the brain from the frontal lobes, and he says that is a euphemism for chemical lobotomy. Okay, in other words, the lobotomy effect is the desired effect of the treatment, saying the antipsychotic effect. So, then there's the famous story of Rosemary Kennedy, the daughter of Joseph Kennedy, the sister of JF Kennedy, and she at 23 years of age was kind of hard to handle for her parents, and they sent her for a lobotomy. They kind of hoped it would just cool her down, that they put her in a convent. She snuck out of the convent, hanging around with men she shouldn't have been hanging around with. So her father sent her for a lobotomy, and she had a bad outcome. She didn't recover well from that at all. So anyways, the other thing too, morally it seems less bad to give somebody a chemical lobotomy than a surgical lobotomy. But man, a lot of these patients have really bad outcomes. Bregan says the antipsychotics damage to the D2 type dopamine receptor in the frontal lobes, is significantly blocking neural connections to the frontal lobe, cerebral cortex, to the basal ganglia, which is subcortical, below the cortex, and to the limbic system. Limbic system includes the medial temporal lobes. And that the antipsychotic effect is, again, like a surgical lobotomy. It damages essentially about the same areas of the brain. He feels it's, basically the same thing, like a surgical lobotomy. And these patients, again, get apathy. They become indifferent. And that's why they're less annoying to the staff at a mental hospital. They'll just sit in their bed and not do anything rather than potentially be in the hallway and being annoying. Antipsychotics are used by the Russians to control dissidents. They'll say, oh, that person's crazy. Give him an antipsychotic. Basically fry the guy's brain. It's been a recent trend, more and more, be giving antipsychotics to children who misbehave. They get all kinds of crazy diagnoses. They get labeled as bipolar. Dr. Bregan says giving antipsychotics to children should be forbidden. Thomas Schaas said to give these psychiatric medications to children is to poison them. So, you say to yourself, does medicine need love? Oh, you bet it does. Because if somebody loves somebody, they wouldn't give somebody a toxic medicine like this. And what I actually think is needed is doctors need more intellectual curiosity. Pick up a book. Psychiatrists, read this book. You know what? If you could refute this book, send it to me a comment or tell me what to read. I'll read it. I would love to be wrong about this. It's kind of sad. It makes me think, my father, I know he really meant well, but was he doing stupid stuff in his practice? I don't know. That's kind of sad. But man, psychiatry is looking to me like the worst field in all of medicine the more I read about it. And I've read a pretty good amount about it now. Okay, antipsychotic side effects, just a few other things. We talked about the PET scan showing diminished metabolic activity, and that's what you also see with dementia. Whereas the unmedicated schizophrenics, this is schizophrenics, but not on the antipsychotics, they'd have normal blood flow in their frontal lobes. Normal volunteers would have normal blood flows. Tardive dyskinesia, it's usually irreversible. It's about a rate of 5% each year that the person's on antipsychotics. So the longer they're on them, the more they get. It's a terrible side effect. Tardive dementia, and let's see. Oh, and there's other things I read. I'll have some of the references later and stuff, and I started reading about antipsychotics clearly have an inhibitory effect on mitochondria. They inhibit complex 1 in the electron transport chain. That is bad. Oh, just a few comments from Grace Jackson's book. I actually had a really nice slide, but I somehow, this program's a pain in the butt. It doesn't save automatically when you close the program, and I forgot to save the slide. And she basically goes through the pathology studies. A guy named Jellinger up there in 1977 had a really big comparative autopsy study of schizophrenics without antipsychotics, schizophrenics treated with antipsychotics, and control patients, that didn't have either of those issues. And so he showed a lot of brain damage findings on the histology of patients treated with antipsychotics. So that was kind of a nice thing. And her book's actually very clever. We're not going to get into it today, but her book is clever. She's a bright lady with an interesting way of looking at things. She really sort of synthesized things from a basic level. Really interesting. She's got more pathology and imaging correlation than Bregan does. Grace Jackson, she quotes Genesis, and she says, "And the Lord said to Cain, 'Where is your brother?' And Cain said, 'I know not. Am I my brother's keeper?' And God said, 'What have you done? The voice of your brother's blood cries unto me from the ground.'" So that's kind of like what Bregan said. People need to love each other and be nice to each other, or they just end up hurting each other. And so love is a very important thing in medicine. It's a super important thing. Why did we talk to our parents? Because we know our parents love us. We can kind of judge their advice. And so what I'm trying to say is, there's all this stuff. Oh, we only care about science. Oh, we only care about science. Well, when you only care about science, a lot of bad things happen. So, if people care about each other, really want the best for each other, and try to be loving and helpful and thoughtful, a lot of these schizophrenic patients actually get better in soteria. And patients with all these other psych problems, whatever it is, dementia, depression, anxiety, you name it, they do better. The kids with hyperactivity. And look at the food. Food affects mood. Food affects psychology. Food affects whether or not a kid is hyperactive. I'm not saying it's the only thing. And Bregan says that a lot of his depressed patients, they have depressing lives. They're stuck in a sad situation for financial reasons, for family reasons, etc. And, you just have to make the best of it. But it can be sad. Anyways, here's just a couple references. We talked about the books. Interesting paper, again, showing electron transport chain complex number 1 inhibited by antipsychotic medications. Another paper showing the same thing. And believe me, there were additional ones too. I didn't want to go through the effort of citing all of them. And here's something quite interesting. Antipsychotic medication inhibiting L-type calcium channels, the NMDA receptor of glutamate in the hippocampus. So that's a big statement. What they're saying is it was having an excitotoxin effect. And that was kind of what I've talked about in my other lectures. You keep on ramping up the metabolic demand of these neurons, and you can't match that with glucose and oxygen delivery, that neuron's going to die. And so you're going to lose neurons. You lose neurons in the hippocampus progressively, you're going to be demented. You're not going to be able to remember things well. So it's sad. And so what I'm saying is, how awful is this? This medicine inhibits mitochondrial function, and it causes an excitotoxin effect. It double screws the neuron by raising metabolic demand through an excitotoxin effect while simultaneously knocking down energy production by inhibiting the mitochondria. So it's screwing the neuron, saying, make more energy, but haha, I'm not going to let you do it. The neuron's screwed. Okay, that's bad.